Anyway, the last talk, and I'll try to end a couple minutes early, blood, the liquid tissue transplant. So the whole notion about this talk is to try to rethink about how we think about blood. I think for years we thought blood is good, blood provides volume, blood provides oxygen carrying capacity. What's wrong with that? And when you really start diving down a little bit, there are other issues that come up. And one way to think about them largely is to step back and realize that blood is taking tissue from one person and delivering it to the other person. And just like any transplant, you get some problems with that. Now, the traditional problems that we've thought about with blood are pretty much all infectious or immediate allergic reactions. So I trained in the era of the emergence of the AIDS infection. And so, God, transfusion and AIDS were very intricately connected, and people were very scared about that, appropriately so. I also trained in the era when hepatitis C did not exist. Well, what was hepatitis C before it was hepatitis C? It was non-A, non-B, because we didn't have a name for it. We hadn't found it yet. And at one point, up to 10% of transfusions transmitted hepatitis C. 10% of transfusions transmitted a chronic hepatitis. So those were the kind of fears that we had about transfusion reactions. But now, the blood supply from the infectious perspective has never been safer. So the likelihood of transmitting hepatitis C is down to about 1 in a million now. The likelihood of transmitting HIV is about 1.5 to 2 million. So from that perspective, very safe. Even the risk of transfusion reactions have gone down. Hemolytic reactions, a case maybe every 500,000 times it actually kills the patient. So that's more common than infection. And then less severe reactions occur more commonly. Trolley, what's Trolley? What's Trolley? Yeah, it's one of those acronyms. Like, what the hell is Trolley? Transfusion associated, let's see, Trolley, transfusion-related acute lung injury, which, by the way, is the biggest killer of people related to transfusion in our country. So we don't even really think about it, but Trolley is the thing that kills people most commonly. But even the rate of that has gone down significantly. So Trolley is essentially acute non-cardiogenic pulmonary edema occurring within a few hours after a transfusion, and it's thought to be an immunologic mechanism. But we've gotten a little bit better at screening for that. Largely, the taking away multiparous women donors has dropped the incidence of Trolley because they have a high incidence of having antibodies in their blood against white blood cells, and that is thought to be one of the triggers. But in any case, if transfusions are now safer from an infectious point of view, less immediate hemolytic type reactions, then why not use them? It sounds like a good idea. One of the basic questions about transfusion, though, is why do we do it? What's the point? And obviously, we hope to increase oxygen carrying capacity and oxygen delivery to tissues. And when you start looking at the levels at which additional blood do that, it really doesn't work that well. So paper number 1 is a global summary of how well, when you give patients blood, it's likely to actually increase their oxygen carrying capacity and delivery to the tissue. And it points out a number of things, some of which include that we have some physiologic responses when we become anemic to improve oxygen carrying capacity. So we shift our 2,3-DPG curve over to make it easier to release cells. We improve microcirculatory vascular flow. And some of that is counteracted when you give blood. So blood increases viscosity. It's thought to decrease some of the fine microcirculation. Older blood has different levels of 2,3-DPG that make it harder to hold blood and give blood. And so the net balance is often very unclear that actually you improve anything in giving blood with respect to the oxygen carrying capacity. So if we're not even sure that it really works to improve oxygen, then it really decreases some of the whole justification for ever giving blood. But there are other issues as well. Paper number 2 is from the New England Journal of Medicine, published a number of years back, looking at, in cardiac surgery, the value of giving fresh blood, young blood, versus older blood. So how long can blood be stored in a blood bank? Anybody know? It's up to 42 days. And as you can imagine, things get a little old at 42 days. And the very nature of the economics of blood is that, of course, you want to give the oldest blood first before dipping into the younger blood, because otherwise your supply is going to get old and expire and you just end up throwing it away. So paper number 2 looked at in cardiac surgery, which, by the way, cardiac surgery is our country's largest medical user of blood. They looked at in cardiac surgery, are there downsides of using old blood versus new blood? So new blood was less than 2 weeks old. Older blood was as old as they would give it. And they found a number of effects, but it actually translated even to mortality effects. So the in-hospital mortality was better by giving younger blood. And even at a year out, mortality in the younger blood recipients, 7.4% versus 11%. This is a randomized trial. Makes you worry about the old blood. Not that we have really any say in how old the blood is that our patients get. And as a follow-up to this, a week ago, April 9th, New England Journal of Medicine, so exactly a week ago, published a similar paper in critically ill patients looking at old blood versus new blood. And their conclusion, they found no difference. They found no mortality difference. They found no any kind of clinically important in-hospital changes, old versus new. So the old versus new, it's not clear. Is it just cardiac surgery? Is it maybe nothing? Probably nothing that we're going to overly worry about. But it still means that blood has immunologic and inflammatory effects when we give it. Paper number 3 is looking at what's called TRIM, the transfusion-related immunomodulation effects. It's been found mostly by association that cancer patients who have received blood have a higher rate of recurrence of their cancer. There's viral activation in patients who get blood. Of course, CMV comes directly from donor white cells. So in Europe, donor white cells are uniformly leukoreduced. In the US, that's an incomplete penetration. So it's estimated about 85% of the US blood population, when we give blood, it's leukoreduced, but that's still not 100% penetrance. Question, do transfusions increase the risk of infection? So we're on paper number 4. Points out that 85 million units of red cells are transfused globally, 15 million units transfused in the US. It's thought that about 1 out of 20 patients who enter a hospital obtain a hospital-acquired infection, one sort or another. So given how much blood we give, if there's even a small increase in the risk of infection from getting the blood, then that could have a significant health impact. So this paper was published in JAMA. It was a meta-analysis of randomized controlled trials that specifically looked at infection rates related to blood transfusion or not. And they found that those who were treated with a more restrictive policy, so a higher threshold for getting blood transfusion compared to the more liberal transfusion thresholds, had a higher rate of serious infection. And it said the number needed to treat with a restrictive rather than a liberal red cell transfusion policy in order to prevent one serious infection was 38. And again, if you translate that to millions of people getting transfusions, you're potentially dealing with a lot of infection and a lot of serious infection. Paper number 5, similarly looking at cardiac surgery, each red cell unit transfused was associated with a 29% increase in crude risk of major infection. And it's pneumonia was the chief infection that they saw. Seems kind of odd. You give someone a transfusion and they get pneumonia, but that was their chief association. You also get increased bloodstream infections, which seemed to make a little bit more sense. The next question, is there a relationship between transfusion and adverse outcomes in major trauma? There is yet to be a paper published in the trauma literature that looks at a restrictive transfusion policy versus a liberal one. So we're going to cover a lot of medical topics looking at a restrictive policy, but so far in trauma, nobody's been on board with trying that out. So pretty much people are getting transfused to a hemoglobin level of 10-ish or so. But it's been found in repeated studies that those who get the most blood have higher incidences of poor outcome. Now, obviously, there's a problem with that. It can be called confounding by indication bias. So who's getting the most blood in major trauma? It's the most traumatized people getting the most blood. So it's very difficult to sort out, is it the trauma itself that's killing the people, or maybe the response, our response to the trauma, by perhaps over-transfusing these people. But when they try to do their corrections, and you heard some debate at the panel, they can correct for this, they can't correct for that. When they did as best they could correcting for the severity of trauma and so forth, it did still play out in both papers 6 and 7 that transfusion was associated with poorer outcomes. And one of the papers shows mortality. Both of the papers shows multi-organ dysfunction increases with higher rates of transfusion. So it's cause for concern, cause for pause. I do think, based on a lot of the medical literature, I expect to see some trauma literature coming out looking at a restrictive transfusion policy, but it hasn't happened yet, so we really don't know. Question, are there any data to suggest that packed red cell transfusions are harmful in the setting of acute coronary syndrome? This is really interesting, and again, a not fully researched topic. So you'd imagine somebody's having acute coronary syndrome, part of their heart is being underperfused, it's ischemic, not getting enough blood, and that's the whole problem. So if we gave blood and got more oxygen to the myocardium, then they should do better. Unfortunately, we haven't seen that, and in fact, at least in observational studies, so you have articles 9, observational studies have found clear associations with the more blood you give in acute coronary syndrome, the poorer the outcomes. So Article 9, association of blood transfusions with increased mortality in MI. This was a meta-analysis of the literature. They looked at blood transfusion, liberal or restrictive policy. They started with 729 studies and got it down to 10 for analysis, looking specifically at transfusion and MI. And they found a mortality difference of 18.2% versus 10.2%. So an absolute difference of 6%, so that's about a number needed to treat of 13 or so. Actually, they say 8. I did my math wrong. So number needed to harm or number needed to kill, theoretically, is 8 patients. So for every 8 MI patients you're giving a transfusion to, according to these numbers, you're killing one of them. So very interesting question of how to deal with that literature. What is, I think, more clear are the next series of questions. So how should we manage upper GI bleeding with respect to transfusion? I think in your syllabus, the numbers got a little messed up. But paper number 10 is a, let's see, is this the New England Journal one? No. So paper number 10 is an observational study, which is what a lot of the preceding literature was, looking at red cell transfusion and upper GI bleeding. So this was non-variceal bleeding. And it was a retrospective, again, non-randomized trial, patients undergoing endoscopy, 18 Canadian hospitals for non-variceal GI bleeding. One thing they found, and it holds up in the subsequent studies, is that people had a much higher rate of rebleeding when you gave them blood. So I think that speaks to the whole hypoperfusion, or at least like in the trauma setting, we know that in certain thoracic trauma, that the permissive hypotensive approach results in decreased rebleeding or rate of bleeding. And that's one of the theories here, that if you have upper GI bleeding and you're a little bit more restrictive about how much blood you give, maybe that's why there's clearly a lower risk of rebleeding in patients who get less blood. So they found rebleeding occurred in a quarter of the transfused patients versus less than half of those who were not transfused. And they also found some mortality differences, but again, this was observational, and the sicker people got transfused. But that can't be said about paper number 12, which is the transfusion strategies for acute upper GI bleeding. This was published in the New England Journal 2 years ago, January 2013, the Villanova study. And then paper number 11 is a analysis, essentially, of paper number 12. So this was patients randomized to, again, a liberal transfusion policy or a restrictive one. And the restrictive one is a hemoglobin of 7. So this is now becoming the magic number. So for the restrictive policy, they had to hit a hemoglobin level below 7 in order to get transfused. For the liberal policy, it was a hemoglobin level of 9. And 9, you know, the rule of thumb is roughly multiplied by 3, so 9 is roughly a crit of 27, and a hemoglobin of 7 is a crit of 21. So they made their upper GI patients bleed down pretty far in the restrictive arm before they got blood. And how did they do? First of all, as you can imagine, there was a lot less blood given in the restrictive policy. So those who were in the restrictive arm, 14% got blood, 51% in the liberal policy. So if even just your outcomes are the same, you've cut down on the use of blood products by 2/3. But the outcomes weren't the same. There was actually lower rate of mortality at 45 days in those who got the restrictive approach. So their mortality was 5%, versus 9% in the patients with the liberal approach. And again, this is a randomized trial. So that's a number needed to kill, again, of 25. So if you think you're doing the best you can for the patient, and let's get them blood, and they look sick, and let's do the best we can, that is probably, as Jerry talks about in the whole less is more approach to medicine, one of those places where less is more. If you've got an upper GI bleeder, and they did exclude the grossly exsanguinating upper GI bleeder, but for upper GI bleed, the kind of the usual variety might be going to the ICU. A number of these were in shock, but they're not just like bleeding out in front of you. Those are the patients that clearly did better with a restrictive policy hemoglobin threshold transfusion of 7. Question talks about the summary data in critical care. What have we learned? So that's abstract number 14 that combines 3 different randomized controlled trials, one of which was the Villanova study in 13, with 2 others, and tries to come up with some take-home lessons. First of all, again, those in restrictive arms receive blood a lot less often. That makes a whole lot of sense. They receive blood just over half as often. And in all the studies, they found lower hospital mortality, lower total mortality, number needed to treat to save one life of 33, less acute coronary syndrome, less pulmonary edema, less rebleeding, and less bacterial infection. That all sounds pretty good. There was not a single outcome, no clinical outcome was improved by employing a liberal transfusion strategy. They could find nothing that said, well, it might help here, even if it hurts there. It just hurt across the board. Question, what role should transfusion play in the management of severe sepsis/septic shock? And again, this has been an evolving area of literature over the last 15 years. Rivers came out with his landmark goal-directed therapy study in 2001. And he had a very liberal, very aggressive transfusion policy. So that called for transfusion if the hematocrit was below 30% and the SCVO2 was less than 70%. So that translated in his intervention arm, the EGDT arm, that almost 70% of the patients got transfusion. That's a lot of blood, and that was compared to about 45% in the other arm. And so over the years, as people who followed the sepsis literature know, the bundle that Rivers put together has been picked apart by the crows and said, I don't think we need this, and I don't think we need that. And one of the things that has been picked at is the whole transfusion strategy. So we now have 3 high-quality studies. I think every one of them was published in the New England Journal, looking at the value of transfusion in the setting of sepsis. The first one that came out that I'm going to talk about is the process study that was published May 2014, so not even a year ago. It compared the original Rivers protocol with a less invasive protocol that required transfusion only if the hemoglobin level fell below 7.5 and everybody else got usual care. The restrictive group got a transfusion rate of the liberal group got a 14.4% transfusion rate, about half that in the other groups. And there were no clinical outcome differences. So again, they cut the transfusion rate in half, and everybody did just as well. They didn't appear to do better by not getting the blood, but they didn't do any worse. And one thing I thought was very interesting here, supposedly the EGDT arm in this group was the same as the Rivers protocol, and the transfusion rate was 14%, whereas the Rivers protocol was 68%. That seems kind of odd. It's severe sepsis patients, same protocol. How is it that 70% get transfused in one study and 14% in the other? And it appears that the arm that the original Rivers study, they just gave blood anyway, and it was outside of the protocol. People at that time believed in blood so much that they clearly gave blood well in excess of their own indications, but that has been cut back now. But even in the process trial, although only 14% received blood, 7% received blood in the restrictive arm and did just as well. The next study to come up was the ARISE trial that was just published in October. Again, it looked at the Rivers, supposedly EGDT protocol, and usual care. And one of the differences between ARISE and process was tertiary care, academic U.S. centers. The ARISE study was rural care, multi-country care, city care. It was sort of everywhere. And how well did people deliver care for severe sepsis? And again, the more aggressive, higher threshold transfusion protocols doubled the frequency of transfusion and had no effect on clinical outcomes. And they also way cut down on how much blood was given, as you can once again imagine. So the final article I'm going to talk about is called number 16, Lower versus Higher Hemoglobin Threshold for Transfusion in Septic Shock. So this was a study that just came out, again, in October, that looked specifically at transfusion value in sepsis. And just like the 2 studies we really just talked about moments ago, they found that in their threshold was 7% or 7 grams per deciliter threshold hemoglobin, that those patients did just as well as a more liberal transfusion policy. So an editorial in the New England Journal that accompanied that paper said, it has become abundantly clear that a transfusion threshold of 7 grams per deciliter should become the new normal, recommended in all critically ill patients, including those with severe sepsis and septic shock. So it's a real reset of, I think, our thresholds. And when I first started training, we had a threshold of a hemoglobin of 10, hematocrit of 30. Get them up to 30, and then if you're given, I remember being taught very specifically, if you're giving 1 unit, give 2 units. There's no point in giving just 1 unit. Double it. give them twice as much benefit. And I think what's clear from the literature is that we're really often not benefiting patients with blood, and in fact, oftentimes we're harming them. So conclusions and key points. The risk of disease transmission from transfusion has never been lower and is roughly 1 case in 1 million units of red cells. So from a direct infectious point of view, blood is really quite safe. Number 2, the body has a number of mechanisms to compensate for anemia, and in most cases, when euvolemia can be maintained or achieved, it's doubtful whether transfusion improves tissue oxygenation, which would be the main reason we'd want to give it. Number 3, like all allogeneic transplants, transfusion, which transfers living cells from one person to another, induces a multitude of immunologic and inflammatory reactions in the recipient and can be responsible for phenomena linked to transfusion, like increased cancer recurrences, higher rates of infection, and multi-organ failure. This effect, by the way, is sometimes used positively because we know in patients undergoing kidney transplant, those who have had a blood transfusion preceding the transplant have a lower rate of rejecting the transplant. So we know that giving blood has modulated their immune system and they're less likely to reject the transplanted kidney. So sometimes it's good, the concern is often it's not. I think so. Number 4, the optimal hemoglobin concentration in patients with acute coronary syndrome is uncertain, but multiple studies have linked transfusion to poorer outcomes. A wise course may be to reserve transfusion in this setting to those experiencing active ischemia that is being medically managed, and even then to keep the transfusion threshold to no higher than a hemoglobin of about 8 grams per deciliter. One of the papers in here that I just rolled over was a summary guideline, I think that was number 8 maybe. I don't know, it's one of these by the American Blood Bank people that came out in 2012 with guideline recommendations, and number 4 was essentially that we can't really say for sure, the literature is not very good in acute coronary syndrome, but what's there is pointing to transfusion being more harmful than helpful. So unless maybe they're having active symptomatic ischemia, that's not going to be treated in the cath lab. And even then, hold your hemoglobin threshold to about 8. Number 5, except in the setting of massive exsanguinating hemorrhage, transfusion threshold for those with upper GI bleeding should be 7 grams per deciliter. Those managed with a restrictive transfusion threshold of 7 have been found to have lower hospital mortality, total mortality, less pulmonary edema, rebleeding, infection. It all sounds good, doesn't it? And that's both adults and peds. Number 7, severe sepsis and septic shock algorithms should all now include a transfusion threshold of 7 grams per deciliter. The New England Journal of Medicine has declared this the new normal, recommended in all critically ill patients. And one point I'll add here is that we know 7 is a good threshold compared to 9, but we don't really know what the ideal threshold is. So, you know, I see in my department mostly medical cases, and the young woman with vaginal bleeding who's just had excessive bleeding and comes in with a hemoglobin of 6. Does she need a transfusion? I don't think so, but there's no great data. So 7 for critically ill people is a very reasonable threshold to stand on. But for less sick people, 6, 5.5, I don't really know.